Hey everyone, Current ECG here. My name's Dave Klein and I need to talk about something that's been bugging me. It's the cardiovascular assessment of our patient. The patient who's complaining of chest pain or chest tightness or squeezing. We encounter this call very commonly in emergency medicine. Lots of patients complain of chest pain. And now, before we get into the assessment of chest pain, let's just reconsider for a second some of the causes of potentially bad chest pain or chest tightness or squeezing or discomfort. Other than ones like myocardial infarction or to layman's terms, having a heart attack, there's other things that we need to consider. Are there potential causes of chest pain that can be catastrophic? Well, I'd say so. How about high dissecting thoracic aortic aneurysm? How about cardiac tamponade? How about pericarditis? How about gallstones? How about pneumonias? How about musculoskeletal trauma? How about pneumothoraxes? There's all kinds of causes of chest pain, and we need to be, always considering ruling in and ruling these out before we focus down one pathway, like myocardial infarction caused by acute coronary syndrome. And what's acute coronary syndrome? It's very simply an occlusion of one of your coronary arteries. Those are the vessels that provide sugar water oxygen to the cardiac myocytes of your heart to keep your heart beating. Now, really commonly in school and in textbooks, when you were talking about doing a cardiac assessment, most of you were taught that you ask these common questions. Let's call the patient Mr. Jones. You go to Mr. Jones, he's complaining of chest pain. So you go over to him, you say, Mr. Jones, please describe your pain. He tries to give you a vague description of it, and you do this. Mr. Jones, I want you to take a nice deep breath for me. Does the pain change for you at all? Mr. Jones, move around, move left and move right. Does the pain change at all? Mr. Jones, I'm going to put a little pressure on the center of your chest. I want you to tell me, does that pain change for you at all? Now, if the pain changes for the patient, that's called reproducible chest pain. And many of us have been taught for some reason that we can use this to rule out acute coronary syndrome or the fact the patient is having a heart attack. That is absolutely not true. Don't do it. Don't get sucked into that old style of teaching and that old way of assessing a patient. Now, we know that the probability of a patient having a myocardial infarction or a heart attack is lowered if their pain description or pain sensation changes, with deep breathing or movement or palpation. It's lowered. It's not eliminated. And we know that, approximately 5 to 10 to maybe some studies say even up to 15% of patients who are actively having an MI will actually experience reproducible chest pain. The pain description and pain feeling for them will change. Some will get better, some gets worse, it moves around, but they're actually infarcting. And so we can never use the fact that the pain for your patient changes as a way to rule out acute coronary syndrome. And many of us have been taught that. And so never fall into that trap. Remember, the probability is lowered, but it is never eliminated. And until next time, sugar, water, oxygen to survive. The eyes can't see what the mind doesn't know. And in Klein's world, who gets an ECG? Almost everybody. Stay current. Join us at www.currentecg.com and be part of the Current community.